Thanks, everyone. Good afternoon. Welcome. It is my pleasure and honor to introduce Dr. Robert D. Friedberg. He obtained his PhD in clinical psychology from the California School of Professional Psychology, San Diego, and completed his postdoctoral fellowship at the Center for Cognitive Therapy, Newport Beach. Currently, he is a tenured full professor, head of the Pediatric Behavioral Healthcare Emphasis, and director of the Center for the Study and Treatment of Anxious Youth at Palo Alto University. Friedberg is a board-certified diplomate in cognitive behavioral therapy, a former extramural scholar at the Beck Institute for Cognitive Behavioral Therapy, a founding fellow of the Academy of Cognitive Therapy, a fellow of the American Psychological Association, and a fellow of the Association for Behavioral and Cognitive Therapy. He was named a Spotlight Mentor by ABPP. Friedberg is the author of 11 books, including Clinical Practice of Cognitive Therapy with Children and Adolescents, New CBT Express. I own all of these books, by the way. The new handbook for CBT for pediatric medical conditions, and the forthcoming Cognitive Behavior Therapy with Youth Tradition and Innovation with Dr. Brad Nakamura. He's also currently at work on a new book on creative applications of CBT with Dr. Erica Rosmid, and a major research project studying intolerance of uncertainty and COVID-related thoughts in children and parents. Finally, Dr. Friedberg has authored many journal articles, book chapters, and national and international presentations. My hero, Dr. Robert Friedberg. Please join me in a warm welcome.
Dr. Stewart, thank you so much for a very gracious introduction. You know, the summary line to that one is, I've just been around for too long of a time. Now, Samantha, are you going to advance the slides?
Yes, let me.
Okay, so if we could put the slides up.
All right, can everyone see all right? Okay.
And again, it is really my pleasure to be presenting. I'm going to talk a little, as we get to the agenda, talk a little bit about where I come from and maybe where I hope we're going with CBT. Okay, so these are the disclosures that we need for CME. We can just scroll through those. And what are we going to talk about? So I'd like to begin, particularly when we're talking about the topics that we're going to talk about, with my origin stories. Because I think for those of you who don't know me, and for even people who, whenever you don't know anyone and you're going to one of these talks, you want to know where they're coming from when they're making the claims that they're making. So I have broken my origin into two parts. One is a personal origin story, and then is a more professional origin story. And then we'll go to the more of the content of the the official content of the presentation, the disparities in behavioral healthcare for youth, access and accountability issues, and then finish up with some recommendations. So if we go to the next slide, Samantha, thanks. And here's my personal origin story. And if we can go to the next slide. That picture is about 50 years old. And who that is that tiny little fellow back there is me at age about 11. And in front of me are my grandparents, my maternal grandparents, Frank and Rose. I grew up in New Jersey in a middle-class neighborhood in a multi-generational house. And if you kind of see the old movies from the 50s and 60s, whatever, that oftentimes Jewish immigrant families lived in one house. So there would be on the bottom of the house was my grandparents, and we lived on the second floor of my brother, mother, and father lived on the second, and us lived on the second floor. I put them on there because my grandfather was an unaccompanied immigrant back in the early 1900s. And again, didn't know a word of English when he came. So he basically had an elementary school type education. And my grandmother, Rose, had to leave school at the end of 5th grade because her mother died and she had to take care of her younger brothers and sisters. I say that because they raised 2 children, my mother and uncle, and education was such a deal for them, big deal, they were insistent that they should be educated. So both of them, my mother and uncle, went to college. That if we go to the next slide, there is my family in front of the bottom of the, I guess, duplex or, two family house, with my brother and my mother next to me. I'm in between my brother and my mother. So in the 30s and 40s, that was a big deal for my mother and uncle to go to college, certainly from parents who were elementary school educated. And there's my brother, and both of us naturally went to college, graduated from college. And again, we were the only people in our family generation of all the cousins that graduated from college. So I say that because I come from a background where education, training, and teaching was a huge value. What did you learn today? Was sort of one of the things that would greet me at home. And even more endearing was my grandmother's insistence is, what did you learn today from me, to learn today in school, Bobby, and what can you teach me? And I would, she would want me to teach her whatever I learned and to quiz her and grade her quiz. And she'd say, how'd I do? And so presenting a material today at such a group as UCSF would be both a dream of my mom and my grandmother. So hopefully up in heaven, they are in the Jewish word kvelling, that from those very humble beginnings, I'm talking to such an esteemed group. Next slide, please, Samantha. So my professional stories, which is probably more dry, I think. And I'll go through that a little faster. Next slide, please, Samantha. So again, I've worked just about, and again, as Dr. Stewart so graciously introduced me, I've been around a long time. So I've worked basically in all of these type of things that's on the slide. And I have always wanted to make what we know from the bench science of psychology, the bench science of psychotherapy research, accessible to the providers and recipients of our clinical services. So that's been a lifelong sort of passion for me. And we've done that at all these different places. Next slide, please, Samantha. So now we get to the more, I guess, scholarly part of this. The disparities in behavioral healthcare in youth. Sadly, there are lots of them. Next slide, please, Samantha. So the challenges that almost 1 in 5 kids and adolescents have a diagnosable illness. Sadly, even in this sort of seminal data by Kadioka, that 3/4 to 80% don't receive care. And it's much more costly to not treat them or not prevent them than to do so. If we go to the next slide, please, Samantha. This is a little bit more recent data from Whitney et al. In 2019 from JAMA, that if you could see, here's the national average, you can see the colors. In California, you could see that of kids who need care, who are psychologically vulnerable, statewide, we're reaching about half, sort of that light blue color. So 1 in 2 are receiving care. If we go to the next slide. Now, COVID, which we're all in the midst of, is a critical incident and is accelerating these disparities. That we're expecting a huge, massive increase in cases in youth. I know that I was just talking to Dr. Martinez maybe 2 weeks ago, and he was saying that as well, that there's just a surge of cases and a surge of unmet cases. So it's making it worse. It's catalyzing these disparities. We go to the next slide, please, Samantha. Sadly, as we drill down a little bit more, specifically, marginalized populations suffer disproportionately in pandemics. So Malam Lund studied the pandemics in history, in particular the 1918 flu pandemic, and about 100 years ago, things haven't changed that much, but in that flu pandemic, marginalized populations got sick first, had lower access to care, had greater job loss, and experienced greater financial stress. So we're still seeing that 100+ years later. Next slide, please, Samantha. Another catalyzing function of COVID is that 800% increase in demand for behavioral healthcare services in the year in which we've had a pandemic. 33% jump in anxiety-related cases. 1 in 5 will experience a psychiatric or psychological sequelae subsequent to the COVID infection. Depression, 4-time increase during the pandemic. That it's even now, as we see as kids returning to school, kids being now perhaps more vulnerable to the variants, that we're going to see greater numbers of children, and these numbers should also rise as well, unfortunately. What's really worrying is pre-pandemic, the suicide rate was the highest since the war years, World War II years. And most experts are worrying that because of the isolation, because of the fears and uncertainty that surrounds the pandemic, that these suicide rates will explode even more. So we have, prior to the pandemic, we had an unmet need. likely during and whenever we get out of this, we enter a post-pandemic period, that need is going to be amplified. So if we go to the next slide, please, Samantha. All of these conditions are exacerbated by our current pandemic, and in pandemics in the past have also been, again, exacerbated. Anxiety, OCD, health anxieties, depression, suicide, they're all characteristic of pandemics. One thing, just as a quick aside, for those of you who are maybe unfamiliar with the psychological characteristics that are, and sociocultural characteristics that are endemic to a pandemic, there's a wonderful book by Stuart Taylor, published in 2019. And when I read this book, I thought, boy, this guy, Dr. Taylor, is a fortune teller. He is really a seer, because everything he wrote in the book has come to pass, including the issues of social unrest. That essentially those things, all of these things we've experienced, have been documented in previous pandemics elsewhere. From the Black Plague to now COVID. So if history is a forecaster, all of these experts are probably going to be right on the ball with this. So if we go to the next slide, Samantha. That the disparities, which were there pre-pandemic, are now ripped open. That BIPOC populations in particular, less likely to have access to behavioral health care for a whole variety of reasons, systemic, financial, reimbursement, all of those things. When they do get access, the access they're getting, are less likely to be genuine evidence-based practices. They're more likely to drop out of treatment and less likely to have positive outcomes. So the disparities are going to increase. Next slide, please. Now, there's a good and bad news. In particular, as we now drill down to California, from Whitney and Peterson's article, if you remember that map, right? We're about at that 53%, somewhere in the 50% range of not getting care. So it's a good news or bad news. Bad news, it's 1 out of 2. However, in California in 2003, it was 81%. So it's better than it was 18 years ago, but still half the kids are not receiving the care that they need. Next slide, please, Samantha. This is really troubling, that when you look at access to inpatient care, the minimum standards by mental health associations is there should be 50 beds per 100,000 patients, 100,000 people in the state. In California, on average, there's only about 30. So we're only about at 60% access in one of the richest states in the country. Or the richest economy. We're one of the, I think somebody could correct me, but I think we're the 8th largest economy in the world, just the state is. So that is really troubling, that there are not a lot of beds for kids. In Northern California, it's sadly worse. There's only 205 child and adolescent beds in Northern California. Southern California is a little bit better, again, relatively, right? It's about, a little bit more than twice as much, but it's still low. So those kids in need, perhaps needing higher levels of acute care or higher levels of intensive care, there's not a lot of access there. Next slide, please, Samantha. So we've talked about the disparities in both in access, in both nationally and locally. Leonard Bickman, who is a who's a real major influence, certainly in my thinking, has a great line, has a great sentiment or maxim, which is sometimes we think that access is the problem, but it's really just a problem. And there's other problems, often less discussed than access. Next slide, please, Samantha. The question is access to what? What are we providing access to? So we can have lots of services, but are those services providing the type of care that youth and family need and deserve? Next slide, please. So access to what? So about 10 years ago, there was a large study in community mental health in California that showed that the rates of improvement in kids, not so great. Less than half the youth improved. 32% had no reliable change, and a quarter deteriorated over the course of care in these centers. Large review of community-funded records that half the charts didn't meet the basic treatment quality indicators, primarily on best practices. I just noticed on my screen that Dr. Accurso is there, and she is, I believe, one of the Erin, you are aren't you one of the mentees of Dr. Garland?
I am.
Yeah, were you actually on that study that's down there?
I was. Yeah.
That's the study?
Yep.
Yep. So she could give this presentation. Kids who received evidence-based practices actually did better, right? So the question is, access is important, but what they're getting access to is also important, but we don't often talk a lot about that. Next slide, please, Samantha. That's the amazing Dr. Bruce Chorpita. And again, just give a little bit of context to that. Dr. Chorpita's, one of his early career positions was in Hawaii, and as part of his faculty duties, he ran the state mental health system, which was in disarray back in the 90s. And so it led to him really focusing on the accountability of available services. And his work that has generated the modular approach to CBT, and more specifically, the modular approach to anxiety, trauma, conduct in youth, the Match ADTC program, and the Managing Practice, the MAP program, has been has been deployed in many states. And those states that have implemented match and map have actually seen an increase in both access, outcome, and provider satisfaction. So that's a good news thing. Next slide. Here's another good news thing, is that CBT responsiveness to diverse youth is one of its advantages. That in a variety of meta-analyses and review articles, particularly Esteban Cardamil and Omar Gudino, who I saw you had on a couple of weeks ago. Again, that was fortunate to work with Omar on an unrelated project, and continue to do so. And his work, again, is really cutting edge on the accountability for CBT with diverse youth. So there's some good news that CBT is effective in African-American youth who are experiencing anxiety, conduct, and trauma, with Latinx youth, anxiety, trauma, and depression. The effect sizes are pretty good. You know, it's, we could really be modest and say 0.44 is a moderate effect size or small to moderate effect size. What it means is about 67% of the youth were better after treatment. When I look at these effect sizes, I'm a little more, particularly with psychotherapy outcome, I'm a little more enthusiastic about any effect size over 3 or 4 or at 3 or 4, because if you think about it, the effect size of low dose aspirin, right? Low dose aspirin supposedly prevents heart attacks. And so it became a federal guideline years ago. Does anybody have a guess as to what the effect size is of the low dose aspirin? It's 0.10. And that's a federal guideline. So if you compare that to, and again, take your low dose aspirin if you need to, right? It's significant, right? But it's 0.10. That a 0.44 is 4 times that. Now the bad news is that there are gaps with Asian American and Pacific Islander and Indigenous youth as well. So more work has to be done on that. Next slide, please, Samantha. I don't know, hopefully you all can see that. It's from the Huey and Palo Store article, chapter, that it kind of reviews all the different research, and you can see, I won't read it for you, you can see that there's some wide applicability to it. Particularly motivational interviewing seems to be widely applicable to just about all youth and adolescents. And then there's some individual variations there. Next slide, please, Samantha. So we have stuff that works and works pretty well. The problem is, how do you get practicing clinicians to genuinely adopt evidence-based practices? And here I'll get on my soapbox just a bit. That what certainly Bickman and some of the other people along those lines seem to suggest is because we have one reimbursement number for all services. So if you're, what is it? It's a little bit over $80 for Medicaid per hour. I see Dr. Stewart saying no. What is it? What is it per hour?
That was my disdain face.
Oh, is it? It's around there, right? So, if we just take that low fee, right, $80+ for an hour, it doesn't matter what you do in that hour, you're going to get your $80, right? So it's 1 hour. So 1 hour with me may not be worth the $80 that 1 hour from Dr. Stewart would get, but I'm getting paid the same amount. So there is no fun. So you're being paid just by time, the 50-minute hour, the 30-minute hour, or when you do CPTs that are CPT codes that are payable in 15 minutes, that 15 minutes, 40 minutes, 50 minutes, they're all the same. They're just time-based. They're not value-based. So what has been found is when you incentivize providers to deliver genuine evidence-based practices, they come through. When left to their own devices or their own incentives, they do whatever they want. So could explain a great deal of the variance in treatment as usual settings. Next slide, please, Samantha. There is that awesome resource. The et al. There is Dr. Accurso. It's an awesome resource. Next slide, please. Okay, so there we go. Now what? So what? Hey, so there it all is. Now what? Next slide, please, Samantha. So in my humble opinion, here are the recommendations. There's nothing like the real thing, right? Remember that old song, ain't nothing like the real thing, right? Coke's the real thing. Yeah, there's nothing like it. So we have to work to help students and trainees and staff develop, unit staff, milieu staff, whatever, to develop to deliver the real thing. We have to balance faithful adherence to the model with a flexible application approach. My hero, of course, is Phil Kendall, and he has been writing for years, since '98, about the importance of practicing flexibly and with faithfulness to the approach. So faithfulness, how do you do that? Stay true to the theoretical model. Construct a case conceptualization that's based on the theoretical model, and then launch the interventions from that conceptualization. Adhere to the basic practices and flexibly apply that. And flexibly applying that is where you can reach the underserved or neglected populations that we talked about who have the disparities. So let's dig a little deeper now. Next slide, please, Samantha. And I already said that, so next slide on that one. Next. So there's another hero of mine, Carl Sagan. And here's the thing, right? For those of you who supervise, again, most of my supervision has been in the past with psychiatric residents. I love child psychiatric residents and fellows. However, they love bags of tricks. And they are relatively And so that they are relatively uncomfortable with the theory that buttress the bag of tricks. So one of the things in training people in CBT is you have to train them in the theory. You have to help them metabolize the theory so they can flexibly apply all the fancy dancy techniques we've come up with. Next slide, please, Samantha. So what's the theories that they got to know? Next slide, please, Samantha. They have to know the basics, right? So I do a lot of training across the country and internationally in community mental health centers, hospitals, et cetera. And almost everybody does parent training, right? I go to the in the group, I said, who here does present training? 70% of the audience say, yeah, I do present training. I said, okay. And then we go over the basics of operant conditioning. And universally, at least a third to a half of the people who do parent training of the groups that I've been to don't understand negative reinforcement. They think it means giving attention to bad behavior. It's really difficult to implement an evidence-based parent training program, whether it's parent management, the Oregon model of parent management, any of these. Look, as Trapita would say, parent training is all about behavior management. It's really difficult to help them manage behavior if they don't understand, if providers don't understand operant conditioning. So we have to help them, we have to teach them that. That should be a core thing in graduate training, in pre-doctoral and psychiatry fellowships. Anytime you're going to have to be doing some sort of parent training or doing functional analysis, right? Functional analysis is a core skill that basically, pervades just about every procedure. Exposure. We're going to talk a little bit much more about exposure in a few minutes, but to do exposure, you have to be familiar with the tenets of classical conditioning. Social learning, Bandura's social learning theory. One of the things, again, it's brilliant. The problem with it is, though, that again, when I was in graduate school, we had to read the original Bandura material, and it's a bit inaccessible. But if you can distill it and digest it and communicate it to your trainees and supervisees and staff, it's really important. So they understand what are the ingredients, what are the nuts and bolts of self-efficacy. It's not just feeling good about yourself, right? There are things that have to occur for somebody to develop a sturdy self-efficacy. Modeling doesn't occur by osmosis. There are 4 component processes to modeling that have to be in place for observation to result in imitation. And information processing. So take our students, our trainees, our supervisees, and help them metabolize these fundamental processes. Next slide, please, Samantha. To conceptualize, to have a pattern of a recognition of pattern, so that they see the theme or the patterns that connect seemingly disparate problems from a learning theory and information processing theory approach. So they're not just putting out fires. Next slide, please, Samantha. And then, of course, from the Beck model, the hierarchical structural organizational model, and content specificity. And again, these are oftentimes when people who are trying to do CBT, and they don't understand the model. That, next slide, please, Samantha. So just really briefly, the hierarchical structural organizational model is a hierarchical layering of cognitive processes that are proportionally tied to the intensity of affect. So if we go to the next slide, please, Samantha, it kind of looks like this. So in the outermost circle are the things everybody knows about, right? Automatic thoughts. They're at the outermost circle. They are tied to emotion, but proportionally. But there are other layers of cognition that give rise and hold automatic thoughts and the distortion process in place. And those are underlying assumptions, sort of the middle layer, the intermediate layer, and then at the center, schemas. So that is really something that oftentimes people who are just trying to do a test of evidence or reattribution or those type of things they neglect or they ignore. So just as a fun thing, when you look at that model, and let's say we weren't talking about CBT and we didn't have those, and you just sort of saw those concentric circles, does it remind anybody of anything? Oh, Andrew, yes. Id, ego, superego, absolutely. The layering and psychodynamic theory, right? That, well, gee, this is one of the criticisms of a Beck approach, is that it's too mentalistic. And it comes from his background, right? Beck was originally trained by Karen Horney. And this was a dynamic. So if you look at that, he was trained psychodynamically, right? And then shifted. But the vestiges of that still stay with Beck, so that's where that model comes from. And remember, Horney had the phrase tyranny of the shoulds, which is, again, a very cognitive thing. I'll just tell you one quick story about Beck and that sort of juxtaposition of dynamic and cognitive behavioral. That frequently when he would do supervision, he would come to us as naive, inelegant therapists and ask us in supervision, tell me what you did and I'll tell you how it's cognitive. And what that taught us is that cognitive therapy is technically eclectic, but theoretically homogeneous. So that it doesn't matter what technique you use, as long as you're faithful to the model, which is based in information processing and learning theory. Next slide, please, Samantha. So again, there's the automatic thoughts, we all know those type of things. And the model teaches us that if you really, again, if you goes down to really a micro skill. So if you want to reliably get what we call hot or emotionally meaningful automatic thought, that the best thing to do is to ask a question like that on the slide rather than what's going through your mind at the moment of a mood shift. Now, why at a moment of a mood shift? Because that all of those thoughts at the periphery, those automatic thoughts, are tied to emotion, to proportional levels of emotion. So if you want to get to an automatic thought, you have to elevate somebody's emotional arousal. Okay, next slide, please, Samantha. And then there's schemata, right, which kind of helps us understand the core beliefs that people have. and where these automatic thoughts come from. Next slide, please. And then there's the cognitive distortions part, which keeps which essentially explains why sometimes that kids, when you're doing cognitive therapy, you'll ask them, how does this new thought seem to fit with you? And they say, I feel it in I understand it in my head, but I don't feel it emotionally. It's because oftentimes they will do discounting or some other cognitive distortion that kind of squishes the information that they're trying to process. And that comes from the schema. Next slide, please, Samantha. So there are some examples of child-friendly distortions. Next slide, please. So the key part is to embed interventions in a case conceptualization that is faithful to the model. From the outcome research, when CBT doesn't perform as well as we think it should perform, when we dismantle the failures there in those studies, the clinicians are not doing what they're supposed to be doing. They're not conceptualizing the case, and that case conceptualization allows for what is now called relevance matching by Charpita, where relevance matching means taking what we know from the evidence from the broad general and making it relevant to the individual so that it's relevant to them. They're either psychological characteristics or sociocultural context. Next slide, please, Samantha. So it is crucial that when we deliver this, that we deliver interventions and techniques that are grounded in a case formulation. Next slide, please. As I mentioned, kind of previewing that case formulation, even if you use a manual, you get one of these multiple manuals, even when you use match and map, which are so effective, they require you to conceptualize the case, to make the manual, to make the technique individualized to the patient. Next slide, please, Samantha. Why? And again, for me and likely for all of you, I have never seen a patient that comes in with a mono disorder. One thing, one problem. They've got 10 problems, right? They've got depression. They've got poverty. They've got substance abuse in the family. They've got boyfriend, girlfriend problems. They've got whatever. And they're setting fires. They're depressed. They're stealing. They're doing poorly in school. And the list goes on. And then how do you deal with those 10 problems? It's a dizzying array. So the case conceptualization acts as a compass, so you don't have to deal with all the 10 fires. Next slide, please. It predicts behavior, manages noncompliance, and then for me, what's really important is it evaluates treatment progress. So how do you know whether it's no progress? What's the difference between no progress, slow progress, and really good progress? What's your benchmark for that? The only way you're going to really know that is through conceptualizing the case. Next slide, please, Samantha. Additionally, case conceptualization allows you to deliver a proper dose of CBT, and it doesn't eliminate errors, but it sure can minimize them. Next slide, please. One thing is cognition hopping, that most kids and adolescents and families that I work with don't stay focused on one thing. So they hop around and everything could sound like an automatic thought, and you end up chasing everything. and jumping from one automatic thought to another within a session without focusing on one, on the core one, attenuates CBT effectiveness. So cognition hopping, how do you know that you're not doing that? You're going to base your intervention on case conceptualization. Next slide, please. Doing superlative work with superficial cognitions. This is something that I have, again, I talk about this, I really feel comfortable talking about this with impunity because I used to do this a lot early in my career, and certainly when I was through my postdoc, is that I would latch on to some cognition and wouldn't tie it to emotion and wouldn't base my Socratic dialogue on my case conceptualization. And I would just not, oh, we're at the 10-minute mark. Thank you, Samantha. We'll be good. I'll be good. So I'll be faster. I'll be faster through some of these slides. I would be just, I'd knock, I'd be, a rock star with some of these cognitions, and I'd, bang it out, and the adolescent or family would go, so what? Okay. Because I didn't tie it to the content specificity hypothesis. I didn't tie it to case conceptualization. Was I doing really good cognitive therapy? No. Were they getting evidence-based treatment? No. I thought I was, but I wasn't. Next step. Getting caught in maladaptive interaction patterns. Who does, again, something I did very frequently early in my career, and hopefully later in my career I do less. But being hooked by the patient, being co-opted by their interpersonal strategies that are unproductive. How do you extract yourself from that? Particularly if you're working with somebody for over a long-term basis. The only way is to rely on that case conceptualization. Next slide, please. Faithful application, adhering to the standard. So that's the adhering to the theory. Here's adhering to the standards and practices and processes. Next slide, please, Samantha. These are the signatures, the imprimaturs of CBT, cognitive empiricism and guided discovery. So important, they rate a 10. Next slide. So collaborative empiricism. Partnering with the patient, not always 50%, but to some certain extent. And then this is really important. The empiricism doesn't have anything to do with the research from the model. It has to do with the fact that as cognitive therapists, we believe that therapy is observable and transparent and quantifiable. We explain what we're doing. There's no mystery to the work. And we measure, we use measurement-based care practices to see what works and what doesn't. Next slide, please. Oh, good, I already talked about that. Next slide, please. Again, a classic thing of empiricism is the use of homework. And again, when we look at all these dismantling therapies, dismantling studies of CBT with youth, when does it fall flat? When homework is not assigned and processed. So again, really adhering to those type of things. Next slide, please. Cognitive therapist has had part of the stance variable is curiosity, right? And helping patients be curious, to search for the possible, to engage in flexible rather than rigid thinking. Next slide, please. And that involves guided discovery. That's the engine of facilitating the possible. And it transcends refutation and disputation. For me in my career, this was the hardest thing to learn and the hardest thing to tolerate in session, which is the object of cognitive therapy isn't to shatter the person's belief, isn't to interrogate the child or youth so that you dispute or refute the thought. The goal is to create doubt where there was once certainty of belief. That you just have to shift the level of certainty from 90% to 30%. Because when kids come in and they think they're a loser or the world is a dangerous place, they believe that to a probabilistic level, to a high level of certainty. And if you just try to create doubt, create cognitive dissonance, it takes away from the opposition that often happens if you're trying to refute or dispute. Next slide, please. But we can skip that. Just talked about that. And I just kind of summarized that. Next slide. Same type of thing. Next slide. Session structure. Another thing to be faithfully adherent to. Next slide, please, Samantha. This seems like such a simple thing, but again, when we found that when CBT seems to be that there's not a lot of research that shows that CBT has negative effects. There are some studies that show that it's neutral, it doesn't outperform some things. When it doesn't do as well as we want, as well as we would expect, when we've looked at the actual processes that are there, is oftentimes the clinicians in the study don't adhere to those session structure things, which is a signature part of CBT. Next slide, please. And proficiency with basic procedures. And they're all the procedures that we all know about. Next slide, please. And this is what I really want to spend a little bit of time with. And then I see us, Barbara saying, can we have a brief Q&A? Yes. One of the things is exposure is so powerful. It is the exposure treatment in anxiety is the thing that explains most of the variance in outcome. And you can see all those different things that, but sadly, even people who identify as cognitive behavior therapists don't use exposure, right? But exposure is really a key element. Okay, next slide, please. Let's take a quick break here for Dr. Stewart's question about Q&A. Oh, we're running close on time.
Yeah, we're close on time. This has been fantastic, Bob. I just wanted to leave some space for folks to ask a question or two before we have to end today's GR.
I'm sorry that I went over, Barbara.
It's all right.
So I'm happy to take questions.
Thank you. Please go ahead and unmute yourself. Or write it in the chat. Sam, I don't know if you're getting any questions. My chat, I don't see any on my chat. Well, I have a question about making this, how did you put it, enticing, doing theoretically based treatment, evidence-based treatment with fidelity or integrity, which I like, I prefer, making it enticing for clinicians to do. And you mentioned the Medi-Cal rate, which is actually $82.17 for a CPT code for a 60-minute individual session, right? What do you propose we do in terms of shifting that? And I'm wondering if there's, yeah, I'll leave it at that.
But Barbara, that's not surprising. What a great question, right? It gets to the sort of the systemic things in our reimbursement issues, right? Now, the last time I looked at the Medicaid reimbursement issues is that they are starting to think about giving premium Medicare payment. So, and then for private insurance, they're also doing this, so that essentially that both the provider and the provider and the institution gets a premium based on their documentation. Usually, at this point, it appears to be written, but there's some movement that they may be requiring people to like record it, or so that they can demonstrate that they're really doing that. And if they're really doing that, there's a greater reimbursement. Additionally, I have a friend who in Pennsylvania who runs a very large healthcare system, and in some states what they're doing is they're also downstreaming the financial incentive to seek genuine-based, evidence-based practices, so that the patient's copay is lower. Now with Medicaid, right, there's straight Medicaid, right, there's no copay, but with private insurance, that they could get rid of their copay if they went to these type of providers and they were really doing that. So just a couple of those type of things that some payers and policymakers are thinking about doing.
Thanks for that.
Any other questions? I want to thank again Dr. Stewart for inviting me. This was, again, I love doing, as you can tell, from my grandmother to you, right? Yeah. That I love kind of talking about this type of stuff. But unlike my grandmother, there's no quiz at the end.
Oh, there'll be a quiz from me for my trainees. That's for sure. Thank you so much, Dr. Friedberg. It's been an excellent time spent with you. And I will be chatting with you over email about other things very shortly. So
awesome. I look forward to that.
Yeah. So thank you so much. Take good care, everyone.
Bye, everybody. Bye-bye. Thanks for coming.